upon Dr. Eman. Dr. Eman from
Yes,
Security
I'm
Forces. Here. Okay, just a few words to introduce you. Dr. Eman is from Security Forces Hospital Dammam in Saudi Arabia. She's a consultant in diagnostic radiology and women imaging, director of clinical medical services at Security Forces Hospital Dammam, Saudi Arabia. As one of the leading figures advocacy for the early detection and screening of breast cancer for women in Saudi Africa, she was the honorary chairperson of the Early Detection Breast Cancer campaign in 2017. Founder of the breast cancer screening program at Security Forces Hospital Dammam, established in 2017. Honored for participating and valuable contributions as organizer and speaker in the success of women's health and imaging conferences, as well as cancer conferences. Honored by Saudi Minister of Health, Dr. Tefik Arabia, for the volunteer participation and work in breast screening at Saudi Cancer Foundation on International Volunteers Day, December 5th, 2027. Now, Dr. Eman. Dr. Eman?
Yes, I'm here. Thank you very much for the nice introduction. And it's my pleasure to be with you today with this international webinar on cancer and breast cancer therapy. I just like to confirm sharing my slides. Is it clear for all? You have my slides. So yes. I will go on. The talk will be about breast MRI indications and impact on therapy. And during this talk, I will focus on a breast MRI indication upon the cancer patients, including recommendations for those patients. We will go through some techniques, protocols, and some dedicated reporting system for radiology. And we will show some examples, benefits of the MRI benefits upon mammography. As you all know, breast cancer screening, the mammography is the only imaging modality that has been proven to decrease breast cancer mortality for the general population. Breast MR has been shown to detect increase the rate of small node-negative cancers in women at high risk for breast cancer. Breast MR is a useful screening tool when used as adjunct to mammography in a high-risk woman. And we will go through certain recommendations as reference to European Society of Breast Cancer, as well as American College of Radiology. So the indications for breast MRI, it includes and not limited to local staging before treatment planning, and this is a preoperative planning. In addition, indication is a positive surgical margin following breast conservative therapy. Adding to this, evaluation response to new adjuvant chemotherapy. Also, evaluation of occult primary breast cancer, where there is evaluation of a patient with metastatic axillary lymphadenopathy and unknown primary malignancy. Addition to that, we do MRI breast for a nipple discharge, selecting cases with unsolving mammography and ultrasound, screening high-risk women, and we will go for these indications. Patients with scar versus recurrence, however, biopsy in these cases will be superior. Evaluating breast implants, cosmetic or oncoplastic for malignant cases. Adding problem-solving tools for equivalent mammography findings. The American College of Radiology recommends annual screening for a breast MRI for a high-risk woman, and high-risk women defined as having BRCA1, BRCA2 gene mutations and their untested first-degree relatives. In addition to this, prior chest radiation between the age 10 to 30, and this is usually treated lymphoma cases. In addition, certain syndromes like Cowden syndromes and others. Patients with a lifetime risk for a breast cancer of 20 to 25% as determined by risk models. Prior diagnosis with a high-risk lesions, for example, tibia, LCIS, ductal carcinoma in situ, ADH, atypical lobular hyperplasia. In addition to dense breast parenchyma on mammography and having a personal history of breast cancer as well. So breast MRI screening is adjuvant to mammography, and alternate mammography exam has to be done every 6 months for those high-risk patients. So a general recommendation to do or to perform this exam has to be done in a dedicated breast unit, and these images needs to be reviewed with a dedicated breast radiologist, and according to European Society of Breast Radiology, the radiologist needs to read at least 150 exams per year, and this is done in a closed MR field with 1.5 Tesla. The patient would be in a prone position using dedicated breast coil. So MRI is a challenging exam for the patient. So imagine with me, the patient would climb upon this table. It has a small gantry opening along the tube. She would be in a prone position almost for 25 to 60 minutes. She would receive an IV contrast. There will be a loud noise. So the gantry opening, there are some limitations, 60 to 70 cm, in addition to the breast coil inside the tunnel, about 1.5 meters. So remember, obese patients, claustrophobic patients, disabled patients, all these are limitations for breast MRI. But we will show you the advantages by reviewing some cases with you. This is mammography for a patient, so 40 years old, not yet invited to mammogram screening, and she had a palpable lump. And as you can see, there are an obvious speculated irregular mass seen on the right breast with a highly suspicious calcification seen on magnified images. This is highly suspicious. Ultrasound done, confirmed the diagnosis by a core biopsy. This is invasive ductal carcinoma. So MRI done as a preoperative assessment for the patients before the surgery assessment. And this is the maximum intensity projection showing an additional abnormal color mapping seen on the left breast. So a second look view done for mammogram, it shows a fatty breast, nothing was there. A second look for MRI demonstrates a highly suspicious cluster-like enhancement seen within the breast. So considering the abnormality within the right breast, this cannot be ignored. So a second look ultrasound done. There was a non-specific cystic changes biopsy done. It revealed a carcinoma in situ. So this has definitely changed the management for the patient from unilateral mastectomy to bilateral mastectomy for the patient. So MR changed the prognosis for the patients. So contrast-enhanced mammography MRI has a high sensitivity, a high negative predictive value with lower specificity, about 80 to 85%. This is another example for a mammogram diagnostic mammogram for a patient presented with a palpable lump, demonstrating the mammogram distortion with a focal asymmetry on magnification images. There was a lot of suspicious microcalcification. The ultrasound confirmed the presence of irregular heterogeneous hypoechoic mass, highly suspicious with a vascularity, multifocal abnormal masses, adding to this abnormal ipsilateral axillary lymph node. Biopsy was performed, revealed invasive lobular carcinoma. So MRI was performed for this patient, preoperative assessment. This is multiple images for MR, color mapping, T1 post-contrast demonstrate abnormal enhancement of the left breast. Adding to this, there was abnormal signal intensity detected on the sternum, low signal T1, abnormal high T2, indicating osteolytic lesion. This was confirmed by the CT scan and changed the management. It was a metastatic bony lesion, so the patient on stage 4. So to obtain this nice diagnostic imaging, a breast MRI, the proper technique and protocol should include and not limited to T2 weighted axial fat suppressed technique, T1 axial non-fat suppressed, 3D axial fat, axial 3D following contrast, total of 6 post-gadolinium pre-breast enhancement, diffusion, and adding some institute will add MR spectroscopy as well. Using of gadolinium-based contrast agent, it's mandatory for assessment breast cancer patients, not necessarily to evaluate implant where it is only for cosmetic reasons. However, if there is an implant with cancer, it has to demonstrate contrast administration. It has to be the dose administered about 0.1 millimole per kg with a bolus administration 2 to 3 ml per second. Then we go through the mass assessment, the margin, the density, the dynamic and morphology as well. Usually we start with the MIP maximum intensity projection images for a lesion detection and characterization that give you the most of information about the disease. And it has to go through the MR lexicon, including the lesion, the architectural distortion, the location of the lesion, kinetic assessment, associated finding intramammary or extramammary, final assessment and recommendation for the surgery, and we need to include the extramammary findings as well that may change the stage of the patient. So this is an example for the different multiplanar reconstruction that demonstrate the axial, coronal, and sagittal image demonstrating the huge enhancing necrotic tumor on the right breast. Another image for unifocal malignancy seen on the left breast of different multiplanar pre and post contrast and demonstrate nicely in the color mapping. And the most important in the post contrast assessment is the subtracted images post contrast, where the parenchyma is totally subtracted. You can see the enhancing abnormality of the malignancy that give you the diagnostic information. Adding to this is this MIP maximum intensity projection that give you an excellent overview, evaluate the quality of the contrast injection, and usually we start reading the images with this MIP. For example, if you receive this one, you know for sure this is non-diagnostic. Whatever the reason, if there is a contrast extravasation, you need to repeat the exam. So during assessment of the breast MR, you need to report the breast parenchymal density according to American College of Radiology and Lexicon, starting from the fatty breast to scattered fibroglandular tissue to heterogeneous or extremely dense breast parenchyma, where the sensitivity is reduced in this condition. In addition to this, also you need to evaluate the background parenchymal enhancement post-gadolinium administration from mild to moderate to marked parenchymal enhancement, whereas the sensitivity for detecting small tumors might be reduced. Then we need to assess the abnormality, whether it's focus, mass, or non-mass-like enhancement. We define the focus when it is less than 5 millimeter. Enhancement that it is too small to be characterized. The mass is a space occupying lesion with a 3 dimension. The non-mass-like enhancement, it is an enhancement in a fibroglandular area without a space occupying lesion. Then we go through the mass and assessment of non-mass enhancement based on the distribution pattern, the internal homogeneous or heterogeneous enhancement, and similar to the assessment of the enhancement. Again, we go through some details of morphological assessment that helps to recognize the mass, whether it's malignant or benign, similar to this speculated homogeneous enhancement or rim-like enhancement with necrotic center. The dynamic evaluation post-contrast is very important assessment, whether there is a washout, plateau, or persistent, that give you an idea when you measure the region of interest, ROI. The analysis of the contrast is very important, that can give you an idea of the mass being malignant, benign, or in a plateau pattern where there is equivocal results. So this is an example for a type A curve where there is a progressive enhancement with a benign lesion. However, this is a type 2 curve. There is a plateau with this huge mass. So again, this is indeterminate. However, when there is a progressive enhancement and a washout, this is a cancer. This is an example for a mammogram of 40 patients with a bloody nipple discharge, where the ultrasound confirmed the presence of irregular heterogeneous vascular abnormal mass. The MR confirmed the presence of the mass. Adding to this, the whole breast give you an abnormal enhancement, abnormal color mapping. When we measure the region of interest, ROI, it demonstrates abnormality, biopsy revealed high-grade DCIS. So the diagnosis is established by combining both morphology and functional criteria of MRI. And the final assessment for MRI, it will be upon the BI-RADS assessment in the report, whereby the BI-RADS 0, incomplete assessment. This is rare using MRI. BI-RADS 1 and 2, negative or benign, so you don't recommend anything except the routine mammogram. BI-RADS 3, where there are probable benign lesions, you need to do a follow-up in 6 months. And BI-RADS 4, where there is a suspicious lesion, you need to do a biopsy. BI-RADS 5, there is a highly suspicious with a probability of 95%. And BI-RADS 6 category, where the patient is known to have a malignant, but you need, there is an additional findings. This is, for example, in a staging. Additional features you need to mention during reporting, for example, a muscle or a chest wall invasion, a nipple or skill involvement, signal voids indicating a marker like this, patient indicating prior biopsy, architectural distortion, or any incidental findings seen within the images that require changing management. For example, seeing this patient MRI breast for assessment of this mass, there is additional ascites in the abdomen, multiple nodules in the lung. CT confirms the presence of lung metastasis. Another example, having left breast mass seen within the left breast for this patient, the incidental mediastinal mass, CT confirmed to have subcarinal mediastinal cyst. So interpretation points is very important. Taking a clinical history correlation mammography is not only diagnostic useful tool, and a positive predictive value for MRI in a high-risk screening population. It is about 3 to 4% prevalence. When mammography was a negative, it's about 0.3% when mammogram and ultrasound is negative, and about 7% if a personal history cancer. And MRI sensitivity also account for invasive ductal carcinoma and invasive lobular carcinoma more than 90%, and DCIS, this is high-grade DCIS, reaching to 90%. For implant rupture assessment, 94%. This is another example for a 50-year-old with asymmetrical dense breast on mammography. The MR demonstrating multicentric abnormality, and the left breast biopsy confirms the presence of invasive lobular carcinoma. Another huge mass seen on the left breast, low T1, high T2, biopsy revealed fulloid tumor. MR demonstrate nicely the vascularity and the color mapping for this, and demonstrate the abnormal enlarged enhancing metastatic lymph node as well. Another example for a 55-year-old patient with distortion only in mammography screening labeled as BIRATS 3. However, MR detects architectural distortion, non-mass-like enhancement revealed invasive lobular carcinoma on biopsy. So in conclusion, imaging has played a significant role in fighting breast cancer. Breast tumor is an exciting but evolving field, and the indication and interpretive guidelines continue to evolve. Women at high risk, as defined by American College of Radiology, should also undergo annual MRI, but this will not exclude mammography. And still, ultrasound is the primarily used as diagnostic tool. Thank you very much for your listening.
Thank you very much.